Chapter 12 discusses disorders of the immune response, including discussion of HIV and AIDS. So, immunodeficiency is defined as an abnormality in one or more parts of the immune system that results in an increased susceptibility to disease states that would normally be eliminated by a properly functioning immune system. There are two classifications of immunodeficiency states, primary and secondary. Primary include autoimmune deficiency states, which are congenital or inherited. There are a wide variety of congenital or inherited disorders that can affect these different categories of immune function, causing immunodeficiency states. But I'm not going to go into the specifics of all of those disorders. There is a chart in your book, 12.1, with all the different disorders listed where you can see kind of the wide variety of things that can go wrong in the immune system leading to immunodeficiency states. It might be good to kind of look it over, but we're going to more specifically focus on just a few things and primarily things that fall into that secondary in nature category. Some of the primary issues will come up later, maybe in some discussions regarding things like kidney disease or in the treatment of various neoplasias. But there are just, a variety and many things that can cause immunodeficiency states. Secondary immunodeficiency states are those that are acquired later in life. And this is, again, just kind of a handful of potential causes that are secondary in nature. So things like significant malnutrition, infections, such as those caused by acquired immunodeficiency syndrome or AIDS, neoplastic diseases, things like lymphomas and leukemias, and things like immunosuppressive therapy, things like corticosteroids, or the medications that we give to prevent transplant rejection in patients. So, result of alterations of the immune system. So, these are the things that can go wrong with the immune system. So, in addition to the immunodeficiency states that we kind of already mentioned, we will also talk about the other three in this presentation. So, things like allergic or hypersensitivity reactions, transplantation rejection, and we'll discuss a bit more about autoimmune disorders. So there are four major categories of immune mechanisms, and these should sound very familiar to you from the conversations we've already had. So humoral or antibody-mediated immunity, largely driven by B lymphocytes. Cell-mediated immunity, driven by T lymphocytes. There's also the complement system and the system of phagocytosis, largely driven by our neutrophils and our macrophages. Alterations in immune function can occur from disruption in any of these categories. If we see B cell immunodeficiencies, those result in decreased Ig production, and this primarily reduces our defenses against things like bacterial invasions. Cell-mediated immunodeficiencies can result in a wide range of responses because T cells have such a wide range of functions. T lymphocytes work collectively to protect against fungal, protozoan, viral, and intracellular bacterial infections. They control malignant cell proliferation, and they coordinate the overall immune response. Activation of the complement system promotes things like chemotaxis and opsonization, which increases or enhances the ability of the immune system to phagocytize invasive pathogens and to lyse bacteria. So alterations in any component of the complement system can lead to enhanced susceptibility to infectious diseases and to the development of a host of autoimmune processes as well. And phagocytosis, a defect in any of these functions or a reduction in the absolute number of available cells, can disrupt the ability of phagocytic systems to function effectively. So people with phagocytic disorders are more susceptible, especially to bacterial and fungal infections, including things like Candida, which is an opportunistic type infection. So we're going to start with discussion of what we call hypersensitivity disorders. The definition of a hypersensitivity disorder is excessive or inappropriate activation of the immune system. There are four distinct types. Type 1 is IgE mediated. Type 2 is antibody mediated. Type 3 is complement mediated. And type 4 is a T cell mediated hypersensitivity disorder. So type 1 immediate hypersensitivity disorders. These are what people think of as those classic allergic responses. In this type of disorder, antigen is replaced with allergen. Environmental, medical, and pharmaceutical allergens are all capable of initiating a type 1 hypersensitivity reaction. So these are things like pollen proteins, house dust mites, animal dander, different foods, household chemicals, and pharmaceutical agents like the antibiotic penicillin. Okay. Um, so the reaction that someone has to these allergens can be localized. So things like dermatitis, so localized, hives or urticaria, or they can be systemic in nature. So things like asthma or anaphylaxis. The cells involved in a type 1 immediate hypersensitivity disorder include T2 cells, eosinophils, and mast cells or basophils. So what's happening is that in response to exposure to an antigen, T2 helper T cells direct our B lymphocytes, and you can see that kind of happening right here, to produce IgE antibodies, which also produce cytokines that mobilize and activate our mast cells, our basophils, and our eosinophils, which causes this inflammatory response through the release of chemical mediators like histamines. And so again, you can kind of see that here. We have this antigen or allergen that causes these T2 CD4 cells to release things like cytokines. Here are ILs. And on this right-hand side, that stimulates this B cell to produce IgE secreting plasma cells. And those IgE secreting cells release IgE antibodies, and those antibodies will stimulate or sensitize our mast cells. And remember that we have mast cells kind of living primarily stored in like the mucous membranes and things. And those mast cells are granulated, meaning they hold a lot of chemical mediators, especially things like histamines. And so now that mast cell is sensitized by the release of those IgEs, it degranulates and releases its chemical mediators. And those chemical mediators, you can kind of see them all listed here, things like cytokines, membrane phospholipids, things like histamines, act to vasodilate, cause vascular damage, they cause smooth muscle spasms, they cause edema of the mucous membranes. Secretions start to form from mucus. Leukocytes start to infiltrate the area. The epithelial lining can start to become damaged. We can get further bronchospasm. So all of these are the potential kind of effects of that IgE desensitization of mast cells with subsequent release of chemical mediators. And so the type 1 hypersensitivity disorders can happen in two phases. There's primary or initial phase response, and that is that time where we're seeing things like vasodilation, vascular leakage, and smooth muscle contraction. That primary or initial phase response usually begins within 5 to 30 minutes of an exposure to an allergen, and usually subsides within about 60 minutes. And it's largely driven by the release of things like histamines and acetylcholines. That secondary or late phase response of type 1 hypersensitivity disorders usually occurs 2 to 8 hours after resolution of the initial phase, and it can last for several days. It's more driven by chemical mediators like leukotrienes and prostaglandins that have similar effects to histamines and acetylcholines, but have a longer onset and prolonged duration of action. So this is a much more intense infiltration of tissues, now with things like eosinophils and other acute and chronic inflammatory cells. And in this phase, we start to see more tissue destruction in the form of epithelial cell damage. So I think the takeaway here is that we do need to not allow these kind of type 1 hypersensitivity reactions to persist and prolong, because the longer that we see this inflammatory driven reaction from hypersensitivity disorders, the more epithelial cell damage that can occur. And so again, this kind of like ongoing inflammatory process does need to be stopped to prevent that tissue damage. So two different types of IgE-mediated type 1 allergic reactions. There is anaphylactic or systemic reactions and atopic or local reactions. So anaphylaxis is a catastrophic, systemic, potentially life-threatening IgE-mediated hypersensitivity reaction. It's associated with just this widespread release of histamine into the systemic circulation that produces massive vasodilation, hypotension, arterial hypoxia, and significant airway edema. So it occurs on kind of a continuum of clinical manifestations that can range from just some confined swelling and hives to a progression to moderate signs like maybe some hypotension, tachycardia, and shortness of breath, all the way to life-threatening bronchospasm, cardiac dysrhythmia, and eventually cardiac collapse and cardiac arrest. So prevention of exposure is best to prevent anaphylactic reactions. People who have known allergens that can cause this should wear things like medical alert bracelets. They should carry personal epinephrine devices, and they should also be instructed that even if they use their personal epinephrine device, they should seek immediate emergency medical care. Some type 1 reactions, though, are atopic or local. So some of the common ones you may be familiar with are things like allergic rhinitis, or just basic things like seasonal allergies, things like hay fever, allergies to pollens, allergies to dust, allergies to animals. There are also atopic reactions that produce immediate things like rash or hives. This is one of the common reactions we sometimes see with pharmaceutical allergens. We can also get atopic dermatitis. Bronchial asthmas are a local reaction to allergens. And the other is things like food allergies are an atopic reaction. The next type of hypersensitivity reaction is the type 2 or cytotoxic hypersensitivity reaction. So these are mediated typically by IgGs or IgM antibodies that become directed against target antigens on the surface of cells or other tissue components. And these target antigens can be either intrinsic or extrinsic. So intrinsic meaning they are inherently part of the host cell, and extrinsic meaning they've somehow been incorporated into the cell surface because of exposure to a foreign substance or an infectious agent. The tissues that express the target antigens determine the clinical manifestations or type of type 2 hypersensitivity reaction that occurs. So these are the different types of type 2 or cytotoxic hypersensitivity reactions. And a couple examples of disorders that are caused by this type of hypersensitivity reaction are things like AIHAs, which is autoimmune hemolytic anemia, Rh incompatibility, or otherwise known as erythroblastosis fetalis. This is something that happens in infants. We'll talk about it a little bit. Also something called good pasture disease is another example, Graves' disease, and myasthenia gravis. So in in picture A here, what is depicted is complement activated cell destruction. And what we're seeing there, the cell that's being destroyed here is a erythrocyte or a red blood cell. And essentially, that phagocytic cell has been activated to recognize that erythrocyte as a cell that needs to be destroyed. And so you can see that that red blood cell becomes opsonized or covered in a coating that encourages phagocytosis, um, probably because of a kind of a substance that's attached to its surface. And so then with that kind of surface displayed antigen plus opsonization, it becomes phagocytized after that kind of activation of the complement system that caused that opsonization. So this is a description kind of what is happening in an autoimmune hemolytic anemia. That's also common to what happens in Rh incompatibility. This happens when there is a difference between Rh positive and Rh negative between a mother and a fetus. And so when that newborn is exposed to maternal antibodies, we can also see a complement activated reaction where the infant's immune system starts to attack and destroy red blood cells due to that antibody mismatch. Goodpasture disease is a complement antibody receptor-mediated inflammatory process where we see these leukocytes and inflammation kind of bodies being activated by the complement system, and then they start to infiltrate different tissues. So in Goodpasture disease, I think it's the tissues typically of like the kidneys and liver that become infiltrated with these inflammatory activated leukocytes that start to cause tissue injury. Here in Graves' disease, you can kind of see this, what we call antibody-mediated cellular dysfunction, where antibodies start to actually attack TSH receptors. And so they sort of bind themselves to those TSH receptors. And then we have that thyroid epithelial cell that because of that binding of the antibody, we get this significantly increased thyroid hormone production and release that's kind of unchecked. And so Graves' disease, if you recall, is a autoimmune disease that causes hyperthyroidism. And kind of the same thing here in picture D. This depicts a antibody-mediated cellular dysfunction that causes myasthenia gravis. And here you can see that normally a nerve ending would excrete acetylcholine to activate that muscle fiber. But in this case, in myasthenia gravis, we have antibodies that have attached to the ACH or the acetylcholine receptors. And because of that, the antibody inhibits the binding of the neurotransmitter to the receptor. And so now we don't get proper muscle activation in that case. So again, these are all examples of the wide variety of kind of type 2 hypersensitivity reactions that we see in the body. So the next type of hypersensitivity reaction are the type 3, which are immune complex mediated disorders. So immune complex reactions are IgG and IgM mediated. And what's happening here is that these immune complexes are being formed in the serum or in the bloodstream, and then they're being deposited in the tissues. So you can kind of see that here. This picture depicts a blood vessel. We can see here's the blood vessel endothelium and the circulating blood inside of that vessel. And we see that we have an antibody that was produced by some B lymphocyte, and it attaches itself to some antigen, forming this immune complex that again travels kind of through the serum. So we have this formation of this antigen antibody complex. And so then the next step is for the deposition of those immune complexes. So once that immune complex becomes activated, it starts to attract other kind of inflammatory cells, um, and it sort of attaches itself or sinks itself into this vessel endothelium. And this process begins to cause damage to end organ vessels. So things like renal glomeruli, the skin, the lung, joints, because it starts to elicit this overall inflammatory response that causes tissue damage, fibrous necrosis to the vessel lining itself. So type 3 reactions are responsible for things like vasculitis seen in many autoimmune diseases, including things like SLE or lupus, and those that we see in things like acute glomerulonephritis. So type 4 cell-mediated hypersensitivity reactions, these are different from types 1, 2, and 3 because they are cell-mediated and they're usually delayed rather than antibody-mediated like the other three were and with more immediate effect. These hypersensitivity reactions can lead to cell death and tissue injury in response to chemical agents or self-antigens. So there are some basic types. There's this direct cell-mediated cytotoxicity. So we see this in the case of hepatitis, where infections with hepatitis viruses cause the cells themselves of the liver to be destroyed, um, which leads to kind of this cirrhosis caused by hepatitis. And then there are also delayed type hypersensitivity reactions. So things like allergic contact dermatitis, this is often associated with things like poison ivy or poison oak exposure, where the exposure to the antigen will take days for the actual breakout of that dermatitis on the skin to occur. And there's also some hypersensitivity pneumonitis. So kind of in the picture here, you can see in A, we have this direct cell-mediated cytotoxicity where a CD8 T cell kills the antigen-bearing target cell. So that again is kind of what we might see in the case of something like a hepatitis. Or we might see this, what we see in B here, this delayed type hypersensitivity reaction, where we have these kind of pre-sensitized or primed CD4 cells. So this antigen exposure, so maybe this is our poison ivy exposure, allowed a cell to present those antigens, and that primed or sensitized these CD4 T cells to release these cell damaging cytokines that then go on to cause those delayed hypersensitivity reactions. So again, this process can take days from exposure for those cytokines to start doing their damage, like things like damaging the skin, leading to kind of that breakout of rash and urticaria that we see in some of those delayed contact dermatitis reactions. The next thing we're going to talk about is some of the immunopathology of transplantation. So just to start out with some of the terminology that will be necessary to understand part of this unit. So a graft are any cells, tissues, or organs that are transplanted from one person and placed into another person. Allografts are grafts that are transplanted from one person to another, and autografts are taken from one part of the body and transplanted to another part of the body in the same person. The donor is the person who provided the graft, and the recipient or host is the person receiving the graft. And transplant success depends on the host's immune system recognizing the graft as much as possible as self. So just going back to something we talked about before, which are these histocompatibility complexes. So MHCs, or major histocompatibility complexes, are those set of molecules displayed on all cell surfaces. And they do things like allowing for appropriate lymphocyte recognition, and they help with antigen presentations. And they control the immune response through the recognition of self versus non-self. So MHCs, and remember those HLAs, are the markers on the cell surface that allow the immune system to determine which cells are self, so they leave them alone, and which cells are non-self that might need to elicit an immune response to protect the integrity of the body. So there are different categories as well of types of transplanted tissue. Some are allogenic, meaning the donor and the recipient are related or unrelated, but they share very similar HLA types. Again, those HLA types being the types of protein markers displayed on cell surfaces, which are different for all individuals. But in the case of an allogenic transplant, the donor and recipient have relatively similar HLA types. We also have syngenic, where the donor and recipient are identical twins, so their HLA types should be very matched. And we also have autologous, where the donor and the recipient are the same person. So there are different types of transplant rejection that can occur after transplant. So they can be cell-mediated, antibody-mediated, or fall into the category of chronic rejection. So in cell-mediated transplant rejection, this is the most common form of acute allograft rejection. And so remember, an allograft is a graft where the donor and recipient have similar HLA types. This is a T cell mediated cellular rejection. And what we're seeing is destruction of the graft cells by cytotoxic T cells because they've recognized those donor cells as a foreign substance. We also have antibody-mediated transplant rejection, and this can happen in both hyperacute or acute phases. A hyperacute reaction occurs almost immediately after transplantation. So the organ is transplanted into the recipient or host, and the minute it is revascularized or is restored with blood flow, this antibody-mediated rejection starts to occur. These are type 3 hypersensitivity reactions. So if you remember what those are those reactions that are mediated by an antibody-antigen complex being created in the bloodstream, and that complex deposits itself into the epithelial tissue, causing things like inflammation and tissue destruction. So what we have are preformed antibodies that are already there and circulating in the body even before that transplant occurs. And these antibodies attack the HLA antigens from the graft, and those antibody antigen complexes deposit themselves in tissue endothelium and the microvasculature and cause immediate tissue necrosis and injury to the graft itself. And we also have acute rejection. This can take days to weeks after transplantation. And the reason it doesn't occur as immediately as that hyperacute reaction is because there weren't as high of levels of circulating antibodies present at the time of transplant. So sometimes we can slow rejection if we give patients immunosuppressive agents even before transplant occurs. But the same thing starts to happen here as what we see in hyperacute reactions, where the antibodies start to, those complexes attach themselves to the vasculature of the graft themselves, causing again things like necrosis and graft injury. In chronic rejection, this is an immune-mediated inflammatory injury to the graft that occurs over a prolonged period of time. And this is usually occurring because we've lost our ability to really maintain good, adequate immunosuppression in the recipient of this graft organ. Patients who receive organ transplants are on lifetime immunosuppression, but many aren't able to reach adequate levels of that, or the immunosuppression that they have achieved at one point starts to wane over a period of time that can cause this chronic rejection. And what happens in chronic rejection is this progressive decline in tissue function because of vascular injury and impaired blood supply to the transplanted graft. Another significant type of transplant pathology is graft versus host disease. And in GVHD, the donor's T cells, so T cells coming from the donor graft, start to react to HLAs present on the host cells. So this is being mediated by T cells from the donor. Incidence correlates with the degree of mismatching between recipient and host HLA proteins. So the closer the match in HLA proteins we can get between donor and recipient lowers the likelihood of GVHD from occurring. But even with good tissue matching, so things like 40%, even with good tissue matching, 40% of HLA identical graft recipients still develop signs of GVHD that require high-dose steroid treatments to suppress them. And graft versus host disease can be both acute or chronic. So prevention of GVHD really focuses on regimens that specifically work to deplete donor T lymphocytes. So immunosuppressive or anti-inflammatory drugs like cyclosporine or tacrolimus or glucocorticoids are often used to block that T cell activation and the action of cytokines that can start to cause damage in GVHD. So the severity of GVHD is really determined based upon the involvement of the three primary target organs that are affected, which are skin, the GI tract, and the liver. So clinical manifestations of GVHD usually develop in the skin first. So things like pruritus or itching, maculopapular rashes, which usually start on the hands and the feet and then extend over the entire area, body surface. Severe cases of GVHD can cause blistering and large skin ulcerations. Gastrointestinal symptoms can include things like nausea, loss of appetite, diarrhea, and abdominal pain. And more severe forms can take the clinical manifestations of GI bleeding, which indicates severe mucosal ulcerations. And in the liver, we can see things like increased incidence of drug toxicity, higher rates of viral infection. We can see things like iron overload, extrahepatic biliary obstruction, and eventually things like sepsis and coma. Severe graft versus host disease is associated with really poor prognosis and has a long-term survival rate of 5%. So again, prevention of GVHD really focuses on regimens that specifically try to deplete those donor T lymphocytes that we talked about earlier. Okay, so now we're going to talk a little bit about the development of autoimmune disorders. So autoimmune diseases occur because of a combination of both genetic and environmental factors. Gender is also a significant component here. We see much higher incidence of autoimmune diseases in women. And the thinking is that this is probably driven by the influence of estrogen. But essentially what we're seeing in autoimmune diseases is a failure of this, what we call self-tolerance, or this failure of the immune system to continue to recognize self versus non-self. So when someone's immune system develops, we also are developing this self-tolerance. And it relies on kind of two coordinated processes to occur. And so there's both central tolerance, where we eliminate any autoreactive lymphocytes during their maturation in the central lymphoid tissues. And then we also have peripheral tolerance, where we get functional suppression of autoreactive lymphocytes in the peripheral tissues if they've escaped destruction in the thymus. So essentially, you're seeing that here in the picture. So we have the bone marrow that has produced all of these kind of pre-T cells, and they travel to places like the thymus to begin to mature. And some of those maturing cells are identified as self-reactive clones, meaning that they're clones that show the ability to attack their own cells, or they don't have good self-tolerance. And so in that case, when those cells are recognized, the body goes through a process of apoptosis, where they are destroyed so they can't circulate in the system and damage our own tissues. This is what we call that central tolerance, where those things are just destroyed before they can start to travel through the peripheral circulation. And so if we have clones that are non-reactive, and so these are good immune cells that won't destroy our own tissues, they go forward and are those that perform these normal immune functions and have good self versus self recognition. So this is what we want, right? But even though we have this central tolerance with this apoptosis and destruction of cells, a few of those self antigens also kind of escape into the peripheral bloodstream. So we see a few self-reactive clones that kind of make their escape. And those cells, through peripheral tolerance, will either kind of be turned off through this process of clonal anergy, or they will be activated for further apoptosis. So just another mechanism for the body to continue to destroy any of those cells that are self-reactive. So people with autoimmune disorders exhibit these hereditary links. So we see higher incidence of autoimmune disorders in things like first level relatives and among certain races. So the assumption is that there is a strong hereditary nature. But what these folks are probably inheriting are what we call susceptibility to genes. So susceptibility genes act in concert with some kind of environmental factor to increase a person's risk of developing that disease process. And those environmental factors or environmental triggers can be things like viral infections, lack of maternal antibody exposure, so maybe lack of exposure to maternal antibodies, maybe through breast milk. They may also be caused by things like maternal smoking or different chemical exposures throughout the lifespan. So there are some criteria that we use to determine if someone has developed an autoimmune disorder. First is the evidence of an autoimmune reaction. So evidence of autoimmunity is indicated by things like history as well as physical findings and serologic findings. And specifically the serologic findings would be the presence of autoantibodies. So we go ahead and correlate physical findings that indicate the potential presence of an autoimmune disorder with the presence of autoantibodies. We also have to determine that those immunologic findings are not secondary to some other kind of condition. So we have to rule out any other cause. And we have to look for any other identified causes of the physical findings that we're seeing of that disorder. So this is why it is can be a difficult and lengthy process to diagnose autoimmune disorders. There are quite a few different kind of complexities to these determinations. So next we're going to talk about HIV and AIDS disease. So first we'll talk about the transmission of HIV infection. The primary ways that HIV is transmitted, one is through sexual contact. That is a primary form of HIV transmission. And just keeping in mind that sexual contact transmission risk is higher among people who also have concurrent other STD infections. And so the reason for this is because STD infections increase the likelihood that someone may have things like open ulcerations on the genitals, and that increases the potential for contact with the virus itself at the mucosal lining during sexual contact. Those with HIV infections and concurrent STDs also experience more symptomatic STD infections, also increasing the likelihood that they would have things like open ulcerations. Another type of transmission is blood-to-blood contact. This is the kind of infection we see through things like dirty needle transmission. So another group that is at high risk of HIV transmission are IV drug users. And then we also see perinatal transmission, where we're seeing transmission of HIV and AIDS from mothers to infant. Transmission from mother to infant is the most common way that children become transmitted with HIV. Also understand that the HIV infected person is infectious even when no symptoms are present. The point at which an infected person converts from being negative for the virus to having the presence of HIV antibodies in the blood is called seroconversion. There are also some things that I would mention as relatively or very low transmission risk of HIV. There is absolutely no evidence that we can have casual transmission of HIV infection. So being passed from person to person who maybe just, live together through casual contact, things like physical, touch, or through sharing household items. We don't see transmission through that way really at all. Also through blood transfusion, the risk right now through blood transfusion in the United States is nearly zero. There is a very small possibility that someone who donates blood prior to their seroconversion may still be able to donate because they would not be HIV positive at the time. But we further lower the risk from this type of transmission by doing screening of any potential blood donors for any high-risk behaviors that would disallow them from being able to donate blood. And the final kind of low transmission that I would mention is through occupational exposure. And that is through things like needle sticks in healthcare workers. Again, transmission is very low. One reason is because of all the added and additional safety measures we've put around things like universal precautions and needle safety. And then we also have good reporting mechanisms and prophylactic medication use that can further reduce that risk of occupational exposure. So next we'll talk about the pathophysiology and clinical course of HIV. So the life cycle of the HIV virus is a multi-step process that we'll talk about and kind of pictured here. But some of the other molecular and biological features of HIV, one thing to know is that it's what we call a retrovirus. Its genetic information is contained in the form of RNA rather than DNA. And it infects a limited amount of cell types within the body. But one major cell type that it does primarily affect are CD4 T lymphocytes, so those cells of the immune system. So again, this is a multi-step life cycle, and the different steps of this life cycle really inform the different methods of prevention and treatment that we use to reduce viral loads and slow the progression of HIV. So the first step in the process of HIV infection is for the virus itself to bind to receptors on the CD4 cells. And they do this in conjunction with the chemokine receptors found on the surface of CD4 cells. The HIV virus has a strong affinity to receptors on the CD4 cell. Once that cell or that virus binds itself to the CD4 cell, it becomes internalized, and then it uncoats itself and begins the process of reverse transcription. And reverse transcription is where it converts itself from RNA to DNA within the host cell. And it does this using an enzyme called reverse transcriptase. Once it has integrated itself into the host's DNA, it becomes what we call a provirus, and it can persist there kind of in a state of latency. So we call this latent HIV infection at this point. Then once that T cell is activated, it starts to replicate. So again, it does this in concert with host T cell activation. And as it replicates and produces more viral RNA, then it can disseminate in that final process where the virus leaves the cell and starts to travel through the bloodstream where it can now infect more CD4 cells. So the treatment of HIV and AIDS relies on the use of different agents or medications that can interrupt all of these steps within the HIV replication process. And so we'll talk about those a little bit later when we get to that treatment stage. So a bit more about the pathology and the clinical course. So that process of HIV replication does kill that CD4 cell, and it kills it as it releases those copies of HIV into the bloodstream. So at the beginning of an HIV infection, even though millions of infected CD4 cells are destroyed, they're being replaced, and the body is destroying most of the viral particles that are released. And so the body itself is really kind of keeping that infection at bay, both by replacing CD4 cells and killing the virus that's being released. But over the years, the CD4 cell count will start to kind of gradually decrease as those viral numbers start to go up. And a person can remain asymptomatic even while that virus load is increasing until eventually the viral load becomes so elevated and the CD4 count drops so dramatically that they start to develop immunodeficiency related symptoms. So at that point, the risk of things like opportunistic infections and death really start to increase. And the point where we see a really large increase in the incidence of opportunistic infections and mortality is when that CD4 count starts to drop below 200. And so there are three kind of phases of HIV infection: the primary phase, the chronic asymptomatic or latency phase, and the overt AIDS phase. And so on the diagram here, we're going to really focus on two lines. One is the blue line and the other is the red line. The blue line is the CD4 count over time, and the red line is the viral load, or the amount of circulating, replicating HIV virus. And so at that acute infection where we have the viral load at 0 and the CD4 count as normal, during that acute phase, we see kind of a significant and rapid decline in the CD4 count, accompanied by a rapid increase in the viral load. But we see kind of a rebound of CD4 cells as the body starts to regenerate them, and the immune system does its work to kill off a lot of that virus that has started to replicate itself. So then a person goes into kind of this latent period where they really don't have any kind of clinical symptoms at this point. But as you can see, even after like kind of this initial drop in viral activity, it gradually starts to increase. And after this kind of initial rebound in CD4 cell counts, they gradually start to decrease. And once those lines kind of, I guess, cross, where we start to see a drop in CD4 count and an increase in viral load, now we have a patient who might start to notice some symptoms of this disease. Maybe they become sick more often, right? And as that CD4 count continues to drop and we get to about that 200 level, we see a rapid increase in viral load. a continued rapid decrease in CD4 counts, and a rise in things like opportunistic infection and eventually death. So the course of HIV, HIV usually progresses to full-blown AIDS within approximately 10 to 11 years. And that is true for about 60 to 70% of those infected. There's a wide range of variation in this rate of progression. Some people will progress much more rapidly, and there are other folks who progress really very slowly. So again, a wide range of progression. So a little bit more though about opportunistic infections, which we've kind of been alluding to. But an opportunistic infection is a common organism that does not usually produce infection unless there is an impaired immune system. So all of us have exposure to these opportunistic infections, but as long as our immune system is intact, they don't make us sick. But in someone with impaired immune function, they will. So there are a lot of things that can cause opportunistic infections. There are bacterial and mycobacterial opportunistic infections that can cause things like bacterial pneumonias like Salmonellas or Bartonellus, M. tuberculosis, Mycobacterium avium. There are a lot of fungal opportunistic infections like Candidus, Cryptococcus, histoplasmosis, pneumocystosis. There are protozoal opportunistic infections like Cryptosporiosis, Microsporiosis, Isosporiosis, Toxoplasmosis. There are viral infections like those caused by CMVs or herpes simplex or herpes zoster viruses, human papillomaviruses. There is the JC virus, which is a causative agent of progressive mycofocal leukoencephalopathy. So a whole host of opportunistic infections. Many of them are kind of listed here, and they can infect a wide range of tissues within the body. Those with HIV and AIDS are also at much higher risk of coronary artery disease. We see that they have accelerated atherosclerosis, which leads to coronary artery disease and heart attack. This is probably due to the overall chronic inflammation and immune activation that become the primary drivers of CAD. Adults with HIV also have higher prevalence of things like diabetes, hypertension, and dyslipidemia. And they also have higher rates of things like tobacco use than we see in uninfected people. Dyslipidemia or high lipid levels are present in more than half of adults with HIV. Respiratory manifestations, a common one is something called P. carini pneumonia. So that's an opportunistic infection that we see commonly in people with HIV. And also things like Legionella infections are common in HIV infected patients. GI manifestations, these are very significant. 75% of people with HIV experience diarrhea, and not just some diarrhea, but significant and often debilitating diarrhea. It's usually caused by a protozoan or a bacteria. And once someone's CD4 count drops below 50, where they have a severe immunocompromise, they are at very high risks of developing chronic colitis that leads to chronic diarrhea. Some CNS or central nervous system manifestations. We see things like the development of cryptococcal meningitis, which is an opportunistic infection, as well as cerebral toxoplasmosis, another opportunistic infection. These patients can develop CNS lymphomas, and they can also develop what we call AIDS dementia. Nervous system manifestations can be things like, again, the things like AIDS dementia, as well as peripheral neuropathies. And finally, things like cancers and malignancies. A common malignancy, the most common malignancy that we see in HIV is something called a Kaposi sarcoma, which is a neoplasm that appears on the skin that we don't see in non-immunocompromised patients. They also develop things like general lymphadenopathy and higher rates of B-cell lymphomas. So prevention is key in the treatment of HIV and AIDS. So things like condom use, same-sex or safe sex programs, the encouragement and educational programs of clean needle use and clean needle distribution have been helpful, different educational and behavioral interventions. Globally, we have seen significant strides in infection prevention and effective treatments. However, there is significant risk right now of worldwide increases in both incidence, prevalence, morbidity, and mortality of HIV and AIDS. This is due largely to the current U.S. administration's stance on HIV-related support worldwide for prevention and treatment of programs. Things like a program called PEPFAR, which was introduced, I believe, in the George Bush Jr. era, which has had really measurable success globally. Since 2010, this program has been able to reduce rates of infection worldwide by as much as 39%. And they've also increased the number of infected patients who are receiving treatment to 77%. With antiretroviral treatment, if we can get people to undetectable viral loads, which is really the overall goal of antiretroviral treatment, those folks with zero detectable viral load can't spread virus to sexual partners. So reducing viral loads is a key part of prevention of spread of HIV as well. Another preventative measure that has shown great promise is something called PrEP. PrEP are pre-exposure prophylactic treatments. Some of them are oral agents, some of them are injectable agents, but regardless of the route of these medicines, if they are taken consistently, they can reduce risk of contracting HIV by up to 99%. And they're most effective when combined with things like condoms or other preventative tools. But we recommend these to anyone who is sexually active with a known HIV positive partner, or anybody who's sexually active with men who have sex with men, anyone who has more than one partner or partner has more than one partner. So anybody with some of these high-risk sexual profiles, anyone having anal or vaginal sex and not consistently using condoms should consider PrEP. And anyone with intravenous drug use who shares needles, syringes, or other equipment. The only real stipulation to not be able to use PrEP is you do have to be HIV negative at the time of its implementation. So anyone who is exploring the use of PrEP does need to be tested and excluded from HIV infection before starting use. As far as diagnosing HIV, we have several diagnostic tests. We have the enzyme immunoassay tests, and these are more kind of screening methods. And then we have Western blot antibody infection tests, and these are confirmatory. So HIV antibody test procedures consist of screening people with these enzyme immunoassays. We also call these ELISA tests. And if someone tests positive on an ELISA test, then we follow that up with the confirmatory Western blot assay. So that's performed after. So again, those two things are tests for antibodies against HIV infection. We also have something called a PCR test, and a PCR test will detect the actual virus instead of antibodies. And we often use these PCR or polymerase chain reaction tests in infants, because an infant will have its mother's HIV antibodies circulating their past during birth, but it doesn't necessarily mean that they have the virus. So that's why we use a PCR test that detects virus in infants instead of antibody tests. Treatments are primarily pharmaceutical agents that target any one of those steps that we discussed in that HIV replication process. So some drugs and some of our earliest drugs destroyed that reverse transcriptase enzyme that was required for reverse transcriptase to occur. So again, reverse transcriptase inhibitors. We also have protease inhibitors, and these help to inhibit that kind of uncoating of the virus inside of the host cell. We also have fusion inhibitors that prevent that adherence of the HIV virus to the CD4 cell itself. We also have integrase inhibitors that prevent the HIV RNA from integrating itself into the host DNA. And often we use a kind of multi-drug combination where we'll use several different types of drugs at once to reduce that overall viral load. But essentially all medications work to disrupt viral replication at some point. The final thing we'll talk about is HIV infection in pregnancy and in infants and children. So infected women may transmit the virus to their offspring in utero, during labor and delivery, or through the breast milk. So during any one of those points. So it is recommended that all pregnant women be tested for HIV at the time of diagnosis of pregnancy, and then that they be tested again at the time of labor and delivery to ensure that no further HIV infection has occurred, or that perhaps they were in a pre-detectable or pre-seroconversion point during that initial test. Diagnosis of HIV infection in children born to HIV infected mothers can also really be complicated by the presence of those maternal HIV antibodies because they can cross the placenta into the fetus. So again, to test for HIV, we use those PCR testings to try to eliminate that confusion. Those antibodies usually disappear within about 18 months if a child is uninfected. So we can do follow-up testing within 18 months to ensure that there's no further antibodies as well as no further HIV infection. So administration of antiretroviral therapy to the mother during the entire length of pregnancy and during labor and delivery is essential to prevent that transmission or transfer of HIV to the infant. And when the infant is born, we give the infant antiretroviral therapy to further decrease the likelihood of perinatal transmission. So those are kind of the two key pieces of preventing this. And this is another thing that over the years we have been able to, through all of these measures, significantly decrease the transmission rates that we're seeing from mother to infant.